Okay, so my name is Lesego Mawela. I'm the founder, director of the Aqua Training School, the Aqua Group. Yeah, I think some of you, we've been meeting every evening, at 8, and I'm happy that you are able to join us again today. Today is a very important session without a lot of cases, but just some theory around certain important concepts which have now informed the change in the guidelines, which I want to really share with you. So yeah, so let's start. Just to say that you won't be able to unmute your mic, at least until the end of the session. I would like to encourage you to use the chat for any comments, questions that you might have. And then towards the end of the session, I will then make some time to take you through, to go through your comments and questions and trying to clarify some of the issues. All right, so thank you very much for that. Let us start. Just to say that the focus for today, it's not a clinical case scenario like we usually do. I just want to focus on the theory, regarding the current changes in the guidelines, particularly a decision by the National Department of Health to allow for dolutegravir to be used as part of both the first and second line ART regimens, right? But that obviously is informed also by changes which now allow us to use dolutegravir safely also in pregnancy. So we are going to discuss that. So these are the key two topics. But before we even start, to talk about dolutegravir, I've just selected few slides which I think are important just to build the context around why there is such a drive, to really get dolutegravir to be part of our first and second line regimens. I also want to say, yes, dolutegravir is a good drug, it's quite potent, but there is a change, right, in the environment, and that change is probably the main reason why we need to introduce dolutegravir as part of our first line, and that change particularly is the prevalence of drug resistance in South Africa. So we know that we have had an HIV/AIDS program, or the introduction of ARVs in South Africa, since around 2004, 2005. And since then, we have seen the emergence of acquired drug resistance, which usually happens when the genetic makeup of the virus changes such that the drugs that we use are no longer working as effective as they should. And we call it acquired because then there are factors that drive these mutations, mainly from poor adherence, people who stop and start, sometimes with medically when we don't pay attention to drug interactions, and so on. Unfortunately, there are those who would then who would then be infected with a virus, that has already mutated. And this group of patients, most of the time, they have never been treated with ARV. So imagine that you are being infected for the first time with HIV, and unfortunately, the person who's infecting you already has a mutant virus, And then there's now a classification that we call pre-treatment drug resistance, which involves a person who is starting ARVs for the first time or who is being restarted, right? Who already has some level of mutations in terms of the virus they have. So the key issue why our first line regimen needs to change is because we are seeing an increased incidence and prevalence of drug resistance in South Africa. And the key recommendation really globally is that when you reach a certain level of prevalence, your first line regimen needs to change. But acquired drug resistance is not something that we should, obviously it's something we want to avoid, but we also need to sort of start to agree that it's inevitable in the context of South Africa, where we have over 7 million people living with HIV and AIDS, and eventually we want to put all of them, on ARVs. So the more people we put on ARVs, we expect that they were going to have some challenges. We are not going to cope as a health system. Sometimes we've got drug stock outs, also our patients become tired and fatigued of taking these drugs. So the issue of acquired drug resistance is inevitable. It's not something that we can 100%, avoid, especially in the context of using what I would say is a weak first line ART regimen, right? And that is why we want to improve that. So if you look at some of the national survey results, if you look at 2013, 2014, you take patients who had 1 or 2 viral loads more than 1,000, you'll see that more than 96% of people who have at least 1 high viral load, they would have at least 1 key mutation. So you'll see out of 100, almost everyone is red, right? So 96% would have at least 1 mutation. But what I want you to pay attention on is this particular group here, that the majority of the mutations that are in circulation in the community, it's mutations against our NNRTIs, right? And this is your nevirapine and efavirenz, right? And some NRTI mutations, especially your K65R and your M184V. So this mutation here is for lamivudine. This K65R is mainly for tenofovir and abacavir, as your NRTIs. But you see that if in South Africa, our first line regimen is made up of NRTIs and efavirenz or nevirapine, that means you've got a very weak ART regimen, because the majority of people who are going to be failing treatment or even infecting other people, they are going to be transmitting a virus where efavirenz and nevirapine with some NRTIs are already compromised and not working, right? Again, this is for second line. So if you look at patients who are taking second line ARVs with a high viral load, you'll see that there's now fewer. If you look at the previous slide, if you look at those taking first line, look at the rates. They are everywhere, right? If you look at those taking a lopinavir, ritonavir-based regimen, very few people would have mutations against lopinavir, ritonavir. But even amongst our second line treatment failures, look at the dominant mutations that you find are still mutations from our first line regimen, particularly nevirapine and efavirenz. And obviously, this has to do with the use of these drugs. We have used them for years. These drugs have a low barrier to resistance. That means if you miss the dose once, twice, you don't take your drugs as frequent as you should, you would fail very quickly, and we use these drugs again for PMTCT. So we are widely using, your NNRTIs across the different programs. If you look at pre-treatment, remember we said when we say pre-treatment drug resistance, we're talking about people who are initiated for the first time or reinitiated, who already, before you even start them on ARVs, they already have some mutations. And you can see the most common mutation is your K103N, which was about, let's say around 6%. This particular mutation, again, is related to your NNRTIs there, which is your efavirenz and nevirapine. So if you think of it carefully, it means if you are going to initiate a new patient on a regimen that has tenofovir, lamivudine, and efavirenz, a big portion of those patients have already failed before you even start them on that regimen, because this is now a mutation that is in circulation, in the country. And then also the majority who are going to have high viral loads later on are patients who are taking your NNRTI. So we generally have a weak first line regimen. This is again children. Look very carefully, right? This is South Africa there. I hope you can see South Africa. Look at the prevalence of mutations in children, right? Children pre-treatment, children who have not been on ARVs before, but now they need ARVs, about 60%, you know, of mutations that are found in those kids, particularly from kids who have failed. From mutations that would make efavirenz and nevirapine to be less effective. So, which is quite something to look at. Again, you look at in this the lower one, South Africa there. So South Africa is this the second last bar across, right? You look at your K103, this is your efavirenz and nevirapine mutation. Look at us there, right? Very high compared to other countries in Africa. South Africa, very high. So we have a very high prevalence of mutations that would make our ARVs not to work against efavirenz and nevirapine. But also, if you look at this particular wing here, right, this M184V, which is a mutation against lamivudine and FTC, you can see South Africa again leading. So basically, these slides, without you really having a headache, oh, Dr. Mawela, why are you showing us these complex things? No, I don't want to stress you. But the key message I want to tell you is that, number one, we've got mutations that are in circulation in the country. These mutations have weakened our first-line regimen, right? That means a regimen that has efavirenz or nevirapine. More than half the time, we blame patients. We say you are poorly adhering, but a big portion of those patients would have started ARVs already with a virus which is resistant to nevirapine and efavirenz. So our first-line regimen is very weak. Hence, we've got now a lot of patients who are being transitioned to a lopinavir, ritonavir second-line regimen, which is not easy to take. And really, that is my message with this. And to look at now your NNRTI pre-treatment resistance prevalence, it's a comparison of different countries. Look at South Africa there, right? Look at where we are. This is over 20%. So over 20% of patients really whom we are going to start on ARVs. You know, that means 1 in 5 would have already developed mutations against efavirenz. So why would we want to be initiating our patients on an efavirenz-based regimen, right? The regimen is weak, is very weak, and you can see even WHO, you know, the cutoff line is 10%. We are already at 20% as a country, right? Now, if you do not deal with the situation where you've got your pre-treatment drug resistance, that is more than 10%, we risk to have more deaths because more people won't be controlled. They will have high viral loads and become sick. More people will become infected because those who have the mutations will have high viral loads and continue to spread it. And it becomes a very costly exercise for the country, right? Hence, WHO, right, already in their global action report, they have a recommendation to say countries where we have a prevalence of resistance, particularly pre-treatment resistance in people who have never been on ARVs. You start them on treatment, you realize that, well, they had mutations before you even started them. So if a country like South Africa, where we are at 20%, so the recommendation here is that if this pre-treatment resistance is more than 10%, we need a new first-line regimen. We cannot continue to give a regimen that has efavirenz or even nevirapine because that regimen has been compromised by the number of patients whom are started on ARVs for the first time and already they have resistance against your NNRTIs, efavirenz and nevirapine, you see. So I'm hoping you are following as I tell you, you know, the story. So the recommended regimen, you know, it's a first-line regimen where the NNRTIs are replaced by dolutegravir there. So the recommended first-line regimen globally is a combination of tenofovir, lamivudine, and dolutegravir. We do not want to be putting a lot of both adults and children where we can. We should be avoiding the use of our NRTIs because those regimens are already compromised. All right, so yes, so that is the key message, from me regarding why I started with this complex slides talking about mutations. I don't want you to cram the mutations. I just need you to understand the foundation as to why, as a country, we are now saying we want to, why, DTG, yes, the drug is potent, but the issue is not just that the drug is potent, is that we have a first line ART regimen problem, and that most patients, as we start them on a first line regimen, they already have mutations against the drugs that we want to use. So the second part of my presentation to you is then to say the choice of DTG as the foundation for a potent first line ART regimen. So let's then dive in and look at what are we saying. So you will see now we have an efavirenz-based regimen. We've got the dolutegravir-based regimen. You can see that these benefits of DTG outweigh, any benefit that you think you will have, from efavirenz, and then you would have no motivation really tomorrow, starting from tomorrow, to be looking forward to start a patient on efavirenz because you've got dolutegravir, only where there's really absolute drug-drug interactions and you have no option. That's where you'll probably consider using efavirenz. So TLD provides rapid viral suppression. The dolutegravir, this combination is generally well tolerated. Patients will adhere. It's got a high barrier to resistance. So we are not going to see a lot of patients failing very early as they start ARVs, and it's got no drug-drug interactions with hormonal contraceptives, which is a plus. It's a very important plus because most of our women, they want to have planned pregnancies, but there's still a very, very low risk. And I can tell you at this point, we are so convinced that the risk is so low. It's comparable to all the other drugs. It's comparable to the same efavirenz, such that it is no longer going to be a decision point. We are no longer going to use the issue of teratogenicity or neural tube defects as a reason not to give DTG. That is in the past, right? And then there's also drug-drug interactions that you must pay attention to, and this weight gain, which is also, neither here nor there. So efavirenz is still there. It's got a low barrier to resistance. Most patients will eventually fail. The neuropsychiatric side effects are still significant, and it's got drug interactions with your contraceptives. But the benefit really is in the context of TB, where you can still consider giving efavirenz.
Let's summarize the risks and benefits of the two of the client.
Sorry about that. Right. So dolutegravir, now TLD is now our recommended regimen because it has a superior efficacy. It's got a faster rate to suppression. It is well tolerated. It has a high barrier to resistance. That means even if you forget 1 or 2 doses, the regimen will be very forgiving, and there are no drug interactions with contraception. But there's concerns about neural tube defects. But as you can see, the 0.3 versus the 0.1, it's now regarded as a statistically insignificant difference. Basically, these drugs are comparable in terms of the incidence of neural tube defects. Drug interactions are important, so whenever you give DTG, you always have to check if your patient is taking TB treatment and other minerals or supplements that can actually affect the absorption of dolutegravir. So that is quite important for us to look at it. Now, DTG and neural tube defects. So what is the update, right? In 2018, we had a safety signal that the dolutegravir, you can see here, they thought the incidence was a bit up, but now we know that it is not actually that high, right? And this was mainly from studies done as reported in Botswana. Now more studies have been done, and now we realize that, actually the difference in neural tube defects prevalence between DTG and efavirenz, it is no longer clinically significant. The difference between 7 or 8 incidences between the two drugs, it's not something that should be very alarming. We should still make women aware, to say both drugs can give you some neural tube defects, but there's no significant difference between the two. Even from the same initial Botswana study, which had showed 0.7%, it has now even dropped significantly to almost 0.33. So, generally insignificant in terms of the prevalence of your neural tube defect. So it's not something that we are worried about
So let's look at
anymore, right? The World Health Organization also now changed their guidelines to say DTG-containing regimens are now a preferred first-line ART regimen for all populations, including women of childbearing potential. So we no longer say, no, avoid it in the first trimester. No, actually the first 6 weeks, no. It is now a recommended component of a regimen that we must use irrespective of whether one is pregnant or not, right? Women can still be empowered with knowledge. We want still to involve them in the decision, but the risk and our fears have sort of now been, reassured by science, right? So what does South Africa recommend? So now the EML committee, the National Essential Medicines List Committee, has now reviewed the evidence as well, and they've compared dolutegravir with efavirenz in pregnancy and have determined that the benefits of giving dolutegravir even in pregnancy outweighs any risk that you can think of. Therefore, dolutegravir is now recommended as part of the preferred, not the secondary, as a preferred first-line ART regimen for all adults and adolescents living with HIV, including pregnant women and women of childbearing potential. What does this mean? It means from tomorrow, if I come there and I'm pregnant and I'm 2 weeks old, you will tell me, like you should with any other drug, that there's some risk which is there. I mean, even Panado, there's some risk that it can affect the baby. Fluconazole, you'll just tell me, like any other drug. At the end, you tell me, but DTG will help you. You'll be healthier, and do well. And that is what we are talking about, right? So I want to show you from the official letter, so that if there are, because I know my colleagues, they always say, Dr. Mawela, give us a letter. And yes, please do type in your emails in the chat box there if you are not on our emailing list, because I'm going to be sharing all these documents with you, which are going to make your life a bit easy. So if you are not receiving any emails and you would like to receive emails from, let me start again. There's a document I want to share with you so that, hey, you know what? I've opened a lot of things. Few seconds, let me show you. I think it's this one. Yes, so here we are, updated guidance on the use of dolutegravir in pregnancy. Do you see when it was written? Is it not yesterday? The day before yesterday. And it's from the National Essential List Committee. They summarize the evidence to say why DTG is such an important drug. It is potent, rapid virological suppression, maximally durable suppression. DTG has a higher virological barrier, you don't fail very easy. And then the whole thing around pregnancy, that the risk is normalized. They've also looked at weight gain in pregnancy and that there's no difference between efavirenz and DTG in terms of weight gain. So we are not going to worry ourselves about that. And here's the draft sections. DTG for first line ART regimen, first ANC visit, right? So what is the recommendation? It doesn't matter. We no longer say, hey, first trimester, this. No, if she's pregnant, she's HIV positive, we want to start her on TDF, lamivudine, and dolutegravir, right? But we still want to monitor nephrotoxicity from tenofovir. So so for a pregnant woman, this is the preferred regimen. And you can see, we didn't say first trimester, 2 weeks, no. So that is how we are going to handle it. All right. Again, you look at HIV in pregnancy first visit, pregnant women who are not on ART, right, with normal kidney function without TB. What is the regimen? Tenofovir, lamivudine, and dolutegravir. So there's no other choice. Even in TB now, in the context of a pregnant woman who has TB, right? We still recommend tenofovir, lamivudine, dolutegravir, but then you must add the additional dolutegravir so that it can be taken 12 hourly to counter the effect of rifampicin on dolutegravir. So DTG requires boosting, which is dolutegravir 50 milligrams 12 hours. So what you do, you prescribe the fixed dose combination. Let's say they take it in the morning, you prescribe the additional 50 milligrams to be taken at night. So that's how you do it, right? Women who are currently on tenofovir, emtricitabine, and efavirenz and are pregnant should be transitioned to tenofovir, lamivudine, and dolutegravir. However, make sure that before you transition that the viral load is suppressed. There's a golden rule in HIV care. You should never switch a single drug when the viral load is detectable. So the transition from efavirenz to dolutegravir should only be done if the viral load is suppressed. So that is the golden rule, right? So I was just then, showing you some of the recommendations which you need to be aware of, that as I teach, it's not guesswork, but now we have the science. We follow the science. You will get a chance to ask questions towards the end, because I'm still continuing a bit. There's more that I have for you, right?
Great. Until the unpublished data has been confirmed.
Yes, so let me stop that. It's the audio from my colleague Jeanette. Now, just to remind you a few things about DTG, that DTG may be given to children, adolescents, and adults. The only requirement is that the weight must be above 20 kgs, right? And then also in the context of TB, don't forget to boost your DTG to 50 milligrams 12 hourly. Basically, you prescribe the FDC plus the 50 milligrams to be taken later on, right? So even in children can also take the 50 milligram tablet, right? But remember, the TLD, fixed dose combination, can only be taken by a patient whose weight is above 35 or the age is above 10 years, because TLD as a tablet, it's got 3 drugs. One of those drugs is tenofovir. Now, tenofovir cannot be given to anyone who has a weight below 35 or they are younger than 10 years of age. So I'm hoping you got that. Right? And just to say that, whenever I teach, I say, don't learn these names, the Novacos and the Luvigens, because these are tender names, right? But if you look very carefully, just below the big names, there's the active drugs, dolutegravir, lamivudine, and tenofovir. That's what you need to know, because these names change based on the person who received the tender, and we don't want to spend a lot of time there. These are some of the side effects that you might get from dolutegravir, like your sleep disturbances, So usually if someone is struggling to sleep, I advise them to take dolutegravir in the morning. Sometimes there's nausea, diarrhea, even the headache. We rarely switch because of the headache, but yeah, we encourage the patients to continue. It resolves over time. But where a patient is really not coping, you might consider dolutegravir. And then weight gain in the longer term, so all we want to encourage is that if you have a patient, you are starting them on DTG and they're already overweight, you should encourage lifestyle modifications, not necessarily to change, because you can't change. Remember the same, if you stop DTG, you give lopinavir. Lopinavir can also cause weight gain. Efavirenz can still cause weight gain. So the best thing here is to deal with weight gain in terms of lifestyle modification and maybe consultations with dietitians to support your clients, right? The other side effect is that sometimes when you start a patient on a dolutegravir-based regimen, there might be a temporary increase in your creatinine levels in the blood. And then usually after that, it remains stable. So what you get with DTG is not an ongoing increase in your creatinine levels, right? If you have a patient on TLD, they have the first increase and the creatinine continues to increase. It's probably related to TDF and not DTG. DTG is like there'll be some 10 to 15% increase. Let's say it was her creatinine was 80, it might increase by up to 8 or so to 88, 87, and it stays there. If it keeps on going up 90, 100, then that is a tenofovir associated toxicity or other things, hypertension, diabetes, and not DTG. So we don't switch DTG when a patient is having increased levels of creatinine or a reduction in the creatinine clearance. So that is quite important. All right. And don't forget, as we give more and more people dolutegravir, the drug-drug interactions are going to be more and more important. We have already discussed that if you are giving dolutegravir with rifampicin, make sure that you boost it to 50 milligrams BD. Avoid, your anticonvulsants, if you can, but if you can't, then you might need to increase the dose to 50 milligrams 12 hourly, or even consider changing the anticonvulsants to your second generation and fourth generation anticonvulsants, And then for your diabetic patients, remember, if they are taking more than 1,000 milligrams of metformin in a day, you should probably avoid the use of DTG because it will increase the blood levels significantly to even toxic levels, right? Pay attention if your patients are taking these particular supplements, your antacids, your laxatives. All those things are likely to reduce the absorption of DTG and lead to treatment failure. So drug interactions are very, 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 very important, right? So the issue of client informed choice is still important. Yes, we believe that DTG is safer, but please continue to empower patients, give them the benefits and the risks, advise them why you recommend DTG for them, and then also encourage the use of family planning. So we can't change. These are very important conversations that we need to have. However, DTG is now the preferred recommended drug to be used in pregnancy. So if you look at first-line regimens and DTG, so DTG will be used in children, particularly when children's weight is now, a child's weight is above 20 kgs. You can start now to introduce dolutegravir in the regimen. As you transition them from lopinavir to DTG, make sure that the viral load is suppressed, right? Don't introduce dolutegravir when the viral loads are very high. And when their weight is above 35, you can then give them TLD as a fixed dose combination because you can now use tenofovir as long as the weight is above 35 and the age in years is more than 10 years. So that is quite important. All right. So to summarize, this second part is to say that dolutegravir is a very important drug in our South African regimen, we are responding to a weak first-line regimen, which is weakened by the prevalence of our pre-treatment drug-resistant mutations, and we needed now to have a drug that is well tolerated, high barrier to resistance, and DTG is giving us that. The side effects are few. However, pay attention to your drug-drug interactions, and by God's grace now, the risk of neural tube defects is fading. So it used to be a big issue. It is now becoming something that we believe is acceptable and we can handle. We don't expect to see children, majority of children to be born with congenital abnormalities. All right. So yeah, so that was part 2. Now I want then to take you to the last part, and then immediately after that, I'm hoping that we will have some time for discussions. So now that DTG is like our go-to, is our go-to boy. We are very happy about it. Now I want us to discuss switching stable clients on first and second line ART regimens to DTG. So dolutegravir, we used to say it's recommended for first line. So now we are changing. We are saying actually even for second line, dolutegravir is a drug that we should be using. And let me show you that before I then advise you on how to handle such patients. There we go. So let me show you the communications that I'm going to send to you via email. So when you see them, you remember that, okay, that is what. Then please, you don't keep them with you. You know what I'm showing you. Don't keep them with you. Please share them with your managers, with your facilities. If you are not on my emailing list, share your email address there, and then I will yeah, I'm hoping you can see this. So this is again another one, and this was written way back, right? 5 May already. We were saying, let's accelerate. Dr. Benini is the head of the HIV program in the country. Ne? Dr. Benini, the head of the HIV program in the country. So there's 2 things here. Accelerate switching to TLD in the first line. So patients who are taking tenofovir, emtricitabine, efavirenz, can they be switched to tenofovir, lamivudine, and dolutegravir? So that is the key message. But not only that, accelerated switching to DTG-containing second-line ARV drugs. So patients who are stable on second line, taking lopinavir, ritonavir, and they are virologically suppressed, we may stop the lopinavir, ritonavir, and then switch them to dolutegravir, right? So it's an official communication from the National Department of Health, and I want to make sure that you understand that as I go into part 3, it's not Dr. Mawela's guidelines, right? It's what is expected that you will practice in the country. So do share your emails, and then I will share with you this, right? So as of now, as I speak to you, if you had not already started, dolutegravir is now a preferred drug for both first line and second line. So in terms of first line, TLD is what we want to initiate the majority of our clients. In terms of second line, we want to switch those who are taking zidovudine, lamivudine, and lopinavir, and just replace lopinavir with DTG. And this is what we call ALD. So you've got TLD for first line, and you've got ALD for second line. And whether TLD or ALD, these 2 regimens are very potent. They are well tolerated. They've got a high barrier to resistance, and no drug interactions with contraception. So this is where we are moving towards from now onwards. But I want to tell you something about dolutegravir, and this is, with every time we make changes, there's always a concern, isn't it? So I want to tell you this about DTG, and pay attention to it. Number 1 is that DTG is a very potent drug. It's got a high barrier to resistance, but it can work as part of monotherapy, right? And monotherapy, please listen to me very carefully. There is the obvious monotherapy where a patient has been given one drug, You know, that is very obvious and it should not be done. However, there's what my Dr. Mawela calls, because I'm the one who calls it, I call it clinical monotherapy. What is clinical monotherapy? Clinical monotherapy happens where dolutegravir is prescribed with 2 other drugs. So as you look at the prescription, you believe that the patient is taking 3 drugs. However, because the other 2 drugs have been compromised, that means based on the drug history of the patient, that patient has already developed resistance or mutations against the NRTI backbone, right? Even if the patient is taking the 3 drugs, but because the other 2 drugs have already developed, I mean, the virus has developed mutations and there's resistance. Basically, it's still monotherapy. It's clinical, but it's caused by me and you because we don't pay attention when we prescribe. We don't take proper drug history and understand. So DTG resistance is rare, but it can happen in certain clinical scenarios, like people who with transmitted NRTI resistance. So someone who has already failed tenofovir and lamivudine, and you give them TLD. They'll be taking TLD, but the only active drug there is DTG. So that is clinical monotherapy, and we have to pay attention. DTG is not like lopinavir, ritonavir. For DTG to work effectively and to suppress the viral load in a durable way, you always need at least 1 active NRTI. So that is very, very, very important. So if you start a patient on TLD and this patient has not disclosed to you that, hey, by the way, I was on Truvada, maybe for PrEP and those kind of things, and maybe they've developed some mutations to TDF, you are going to be giving a clinical DTG monotherapy. And that is what we don't want. That is what we are trying to avoid. Bullet 3 is the most common, where a patient is taking tenofovir, tricitabine, and efavirenz, and there's a letter like the ones I've showed you. Hey, switch everyone to DTG, and you are just switching without checking the viral load, right? So this is very important, you know, that you should never switch even from efavirenz to DTG without checking the viral load. If the viral load is high and you switch, you are in essence giving monotherapy to the patient, and DTG is not a very good drug in that context. I know that there's 1 or 2 studies happening now which are trying to validate that, but as I speak to you, we do not recommend that where the NRTI backbone is compromised, that you use DTG. You would rather use lopinavir, ritonavir, and this is what then would explain what I'm about to say, right? So which patients on second-line regimens can be transitioned to DTG? So if you have a patient currently who's taking zidovudine, lamivudine, and lopinavir, ritonavir, you see, and their viral load is suppressed, right? You may switch them to ALD, which is zidovudine, lamivudine, and dolutegravir, but the viral load must be suppressed, right? Now, in the context of someone who's taking lopinavir, ritonavir, and they are taking a TDF-based regimen with lopinavir, this group of patients, you should not give them dolutegravir, right? You can only give dolutegravir to a patient who's taking a standard second line, a basic second line regimen, which is zidovudine, lamivudine, and lopinavir, ritonavir. If a patient is taking tenofovir, tricitabine, and lopinavir, ritonavir as second line, you should be asking yourself, what did they fail when they were taking first line? Probably AZT. You see, now you are going to compromise. This regimen is so compromised. And remember that lopinavir, ritonavir, like I said, it can cope with a weak NRTI, a backbone, but dolutegravir cannot. So if a patient is taking TDF, tricitabine with lopinavir, ritonavir as part of a second line regimen, you should not transition them to DTG. And where there is a stock out, don't say, no, there's a stock out, I'm going to stop lopinavir and give them DTG. No, don't ever do it. You would rather opt for the other protease inhibitors, either atazanavir with ritonavir or duranavir with ritonavir. So that is where you would go. You should never transition any patient who's taking TDF, emtricitabine, or ranitidine with lopinavir as part of their second line. Don't ever transition them to DTG, because eventually they will fail that particular regimen. And the reason why you shouldn't transition them is because of the previous sentences that I tried to tell you here. You don't want clinical monotherapy where TDF and lamivudine are compromised, and you just want to introduce DTG here. It will be a problem. Lopinavir can cope, DTG won't cope. And really, that is the key message that I want to give you. So whether the patient is taking first line or second line, if you want to transition them to a dolutegravir-based regimen, please make sure that they are virologically suppressed, right? If the viral load is higher than 1,000, you should be thinking about whether they need a new regimen. They need to be switched to second line, right? So the first principle is that we must monitor the viral load all the time, at 6 months, 12 months, and then every year. If the viral load is suppressed, less than 50, we are happy. But if it is above 50, you have to check and say, why? Why is the patient having a high viral load? Are there adherence issues, forgetting, lack of support, mental health? Does the patient have the bugs, some infections that need to be treated, correct dosing, and then drug interactions? And then if they're taking lopinavir, ritonavir, we might need to do drug resistance. So you do your A, B, C, D, E. Whatever you find here, you implement, and then you repeat your viral load. Please don't do single drug substitution when the viral load is detectable, right? It's an important principle number 2, to never change only one drug when the viral load is high. If the viral load is less than 50 and your patient is taking efavirenz, you can stop efavirenz and give them dolutegravir. If the viral load is very high, deal with the viral load. Don't switch one drug. Deal with the viral load. How do you deal with the viral load? You do a thorough assessment, you implement your interventions, and then you repeat that particular viral load until you are able to decide, right? And then switching between lopinavir and DTG, these are usually your second line patients. So if you have determined that the client is on a basic second line regimen, which is zidovudine, lamivudine, and lopinavir, and the viral load is suppressed, you may consider to switch them from lopinavir to DTG. As you transition patients to DTG, check the viral load. It must be suppressed. Check if your patient is taking other drugs that may interact with DTG, right? Educate the patient about the new side effects, nausea, the headaches, insomnia, which might happen. And then if she's a woman of childbearing age, you still need to recommend family planning, because family planning is important, and then you provide them with a choice to say, hey, it's your choice. We are not going to force people to be switched. We give them information, but we think that DTG is best. Remember, lopinavir, most of them will be taking lots of tablets, those big tablets, 4 of them every day. The diarrhea and other side effects, high cholesterols. That is why we want to switch them. So even if they are on second line, but they are virologically suppressed, and they are taking a standard second line regimen, which has zidovudine. If someone is taking second line with tenofovir, please don't switch them to DTG. So let's remember that. So to summarize, this topic is to say that DTG is preferred as part of the first line regimen. So that is a tick, right? If you have patients taking efavirenz or even lopinavir as part of first line, and they are suppressed, we should switch them. But now we are saying even your second line patients on lopinavir, ritonavir, if the viral load is suppressed, we can consider switching them to ALD with dolutegravir. Before you switch, make sure that the viral load is suppressed, right? Currently, in the country, there's a shortage of lopinavir, ritonavir. So if you have a patient in your clinic, you don't have lopinavir, ritonavir, and your patient is taking zidovudine, lamivudine with lopinavir, ritonavir, that's easy. You just stop your lopinavir, you give them DTG as long as the viral load is suppressed, right? If there's a stock out and you have a patient who's taking second line TDF with emtricitabine plus lopinavir, ritonavir, you are not going to give DTG here, right? Because most of the time, these patients have a complex history of failing and stuff, and half the time they've already developed mutations, your your K65R mutations and so on. So you would rather stop the lopinavir because you don't have it, it's out of stock, and give the combinations of atazanavir with ritonavir or even duranavir and ritonavir, especially for those who are on third line, right? So that is really the key message from me to you. So let me show you two more things. The first one is to give you guidance on these ritonavirs. So just note that when you get an email from me, you'll have 3 attachments, including this one, which now says, previously we used to have atazanavir and ritonavir as 2 separate drugs, right? So currently in the country, we have a combined tablet of atazanavir and ritonavir. Are we together? And it's taken once daily. That is also the nice thing about this one. So remember, why am I showing you this? We said if you have a patient who's taking tenofovir with emtricitabine and lopinavir, ritonavir, and you have a stock out of lopinavir, ritonavir, and the viral load is suppressed, you don't take them to DTG. You give them tenofovir, emtricitabine, and atazanavir with ritonavir, which is 1 tablet. And also remember, this combination has fewer side effects, right? We also have a combined tablet of duranavir and ritonavir, but this combination here is preferred for your third line patients. So it's usually ordered on a named patient basis. And that is what really I want you to pay attention to. And then just to summarize the issue of transitioning, I want to show you the algorithm and then I'll be done for the day. So here's the algorithm, yes. So here's the algorithm, which I'm also going to share with you for switching stable clients on first line and second line ART to a DTG-containing regimen, right? Number 1, we are saying dolutegravir has benefits, therefore all clients, all of them should be assessed, not some, all of them who are not on DTG should be assessed, and if they are suppressed and stable, they should be considered for switching, right? Also, we are saying both, for now, we include both those who are on first line and second line regimens. Remember, previously we were only focusing on patients who are on first line. Now we are saying both those, all clients on first line and second line regimens can benefit from DTG. But before you switch, you must determine if the patient is eligible for a single drug substitution. What does that mean? It means, number 1, their viral load should be suppressed. You're not going to switch people who are failing, right? And they should be on a standard first line or second line regimen. Remember, I said second line, if they are on AZT, lamivudine, and lopinavir, ritonavir, then you can switch them. But if they are taking tenofovir, lamivudine, lopinavir, you are excluding them. So if your patient meets this criteria, then the first part is to say, does the patient meet the viral load criteria? Is your patient suppressed? That's what we want to know, because if they have a high viral load, you're not going to switch them to DTG. They need a new regimen, not just to switch one drug, right? But if the viral load is suppressed, you provide information to your patient, and then if the client agrees to switch, you switch them to DTG, and that's it. That is the thing. So for a patient to be transitioned to DTG, they must meet a virological criteria, which means they must be suppressed. Number 2, they should be on a standard first-line regimen. Which first-line regimens are we talking about? Here are the regimens, right? So for first line, If you have a patient tomorrow who's taking tenofovir, lamivudine, and efavirenz, and they are virologically suppressed, you can switch them to TDF, lamivudine, and DTG, which is TLD, right? If your patient is taking zidovudine or abacavir with lamivudine and efavirenz, you continue the NRTI background, you switch efavirenz to DTG. Children who are taking abacavir, lamivudine with lopinavir, ritonavir, and their weight is above 20 kgs, so DTG is approved, but the weight is still below 35, so TDF is not approved. So you'll continue the NRTI background, and then you stop lopinavir, you give them DTG. Remember, we're talking about people who are taking lopinavir as part of first line. So pay attention to that. If you have a child taking abacavir, lamivudine with lopinavir, but their weight is above 35, that means you can now give them TLD because they meet both the criteria for TDF and the criteria for DTG, right? Second line regimens, basically only those who are taking a zidovudine-based regimen can be transitioned to DTG. So if they are taking zidovudine, lamivudine with lopinavir, ritonavir, or atazanavir, and they are virologically suppressed, remember the first criteria, you can switch them to what you call ALD, zidovudine, lamivudine with dolutegravir. The following regimens should not be switched to DTG, right? So if a patient is taking tenofovir, lamivudine, and lopinavir as part of second line, right? As part of second line, don't ever. But if this was part of their first line, you can switch. But if they have failed a previous regimen and currently they are taking this regimen, no, don't switch them. If there's a stock out, you would rather stop lopinavir and give them atazanavir. Also, children who might be taking a regimen similar to the first line, but they are taking this regimen as part of their second line regimen, right? If they're taking abacavir, lamivudine with lopinavir, ritonavir as part of their second line regimen, you should not switch them to DTG. If there's a stock out, like I said, you would rather stop the lopinavir, ritonavir, and provide atazanavir for your patients. All right. My throat is so dry. You won't believe it. But I hope I've managed to share with you, the key, and you have enjoyed this particular session. And I see, you guys, you have asked me so many questions. So let me see if I can go through some of them. People want CPD points. I've been postponing this one because it requires a certain level of administration. Let me update you in the next meeting to say what is it really that we can do. We are registered to give CPD points. It's just that the administration for the e-learning sessions. Yes, Dr. Nchang, as you're saying, elderly patient with a high BMI and a suppressed viral load, would you recommend changing to TLD? The answer is yes. We would recommend to change, but then you would need to institute your what you call your behavioral. Remember, the weight gain is not immediate. It's something that happens very late on, and so you would have to institute your behavioral change and helping them to adopt new behaviors, exercise, food, dietitian, Remember, the same efavirenz is known to cause weight gain as much as lopinavir, so the switching won't work. But if they are suppressed, maybe, and I get your point, Dr. Nchangas, maybe you want to keep them on TEE. They will eventually fail that regimen, like I've showed you. So it's best to switch them whilst they're still suppressed. Rabelani, you are saying the maximum is metformin 512 hours. Yes, so in a 24-hour day, if a patient is taking more than 1,000 milligrams of metformin, you should avoid the use of DTG. If a patient's blood sugar is not controlled, are we allowed to increase the dose of metformin? If you increase the dose of metformin to more than 1,000, then you need to discontinue DTG, maybe consider efavirenz. So that is the point there. And then Marcia Roberts, you are saying, I have a client who is taking treatment from a private doctor. They are on zidovudine, lamivudine, and efavirenz. Now, this is very important, Marcia. Don't just switch that patient to DTG. Go get the history. When did you start? Which year? Which drugs were you started on? Why are you taking a funny regimen with AZT? Have you ever been told that you had high viral loads? If the answer is yes, keep them on that regimen. If there's a need to switch them, you would rather switch them to a lopinavir ritonavir regimen. Avoid DTG in patients with a history of many changes and treatment failures, because if the NRTI background is compromised, you'll just put your patient in a lot of problems. And I see you're continuing to say, after recovering from COVID, they started showing signs of psychosis. I wanted to check. Yes, you can give, before you consider DT, please go and take proper history. Call the private doctor and any other doctor, take proper history from your patient. If your patient has never failed ARVs before, they have never failed ARVs before, then you can still give them DTG. But if they have, and the NRTI drugs are compromised, and you switch them to DTG, they are eventually going to fail treatment. And it will be a combination of iatrogenic things. Landiwe, you are saying if a patient is on lopinavir, ritonavir, plus TDF and lamivudine, can we switch to DT? No, don't do it. That is exactly what we are afraid of. And Landiwe, please verify, why are they taking that regimen? If they're taking it as part of second line, you should not switch them to DTG. Keep them on that TDF, lamivudine, and lopinavir, ritonavir, right? Can I switch a 12-year-old weighing 31 kgs from alluvia to efavirenz with, hey, they're going to fail? Alluvia is a very good drug. Even in the context of poor adherence, patients are still able to suppress. So the viral load is 100 copies. Efavirenz is not a very good drug to switch. What I would do for this 12-year-old is to check the drug history. If they are taking abacavir, lamivudine, and alluvia, and this is the only regimen they've ever taken, you may switch them to this thing, because they allow it a bit in the guidelines. But please be very cautious. Try to get that viral load to suppress. Take proper drug history and solve. DTG won't solve adherence. Patients need to be willing to take the drugs. So that is very important. Njabule, you are saying a newly diagnosed HIV positive patient who has TB, patients taking iron supplements. So as I will start the patient tomorrow on TB treatment for 2 weeks, then is it safe to give TLD? Yes, but remember, iron supplements plus dolutegravir, you have two options. They must be taken separately, like 4 to 6 hours apart. So if they're taking your TLD in the morning, it's always best to take the iron supplements at night. If they're taking iron supplements, let's say 8 hourly, then you have to give TLD with iron supplements. They must take both with food, right? Don't forget that the day when you initiate. And because you're talking about a TB patient, your dolutegravir component must be given 12 hours. So you'll give TLD in the morning and then 50 milligrams of DTG in the evening. I saw on the slide that said we can switch pregnant women to TLD if their viral load is suppressed. Aren't we following the same principle? Yes, you are correct. Just that your name is iPhone. So you switch to TLD, the viral load must be suppressed. That is the rule. Dr. Nchanga says, changing a stable patient from lopinavir to TLD, it is because of stock shortage or what? Yeah. So firstly, yes, stock shortage, but also because the DTG is a better drug. It's still very potent, and it's one tablet. Lopinavir patients are taking 2 tablets, it's 4 tablets in a day. The size of the tablets is big. The watery diarrhea is a problem. The body disfigurement with lipohypertrophy, central obesity is a problem. The insulin resistance and the high cholesterols with syndrome X. So really, DTG has a better side effect profile long-term, Dr. Nchangase, for your patient, But remember, you'll discuss with your patient. If they are comfortable, it's fine, but remember to monitor some of these side effects. After all the information on DTG has been given and a patient still prefer TEE, it's fine. It's fine. Yes, remember we said at the end we involve the patients. You would give them the benefits, and if they still feel, no, I love my weird dreams, so keep them on those weird dreams. Talcott, you are saying in terms of no single drug substitution when the viral load is high, does it apply when you are switching NRTIs? Yes, it applies, and usually we talk about if a new patient has taken ARVs for more than 6 weeks, you want the viral load to be suppressed. So if I start you on ARVs today, and then after 7 days, I find that your kidney tests are abnormal, I can just switch you to Abacavir because you have taken ARVs for a week. But if someone has already taken ARVs for more than 6 weeks, that means they were able to mount enough drug pressure to induce mutations. So you want to buy them time. But let me tell you, we don't treat resistance, we treat patients. So if the reason for switching is because there's a life-threatening condition the patient has, we take the risk. But it's not a practice you should be practicing if you are not under pressure to practice it, right? Paul, you are saying if a person defaulted treatment for more than a year, who was on lamivudine and efavirenz and alluvia, should he be started first on the, yes. So when you are restarting a defaulter, you start them on their old regimen first, always, and then you repeat your viral load in 3 months' time. If they are not suppressed, then yeah, you can consider switching them to a new regimen, not one drug, right? And then the Neo Grace, if someone is on DTG and taking TB treatment, how long should we continue the adjusted? It's about 2 to 3 weeks, right? So the question you are asking is, a patient is taking TB treatment and TLD, dolutegravir 12 hourly, right, because of TB. Now they've completed TB treatment, right? Now they've completed TB treatment. So what can you do after that? You continue with your 12 hourly DTG for 2 weeks at least. I'll verify the actual, but it's there in the guideline, the duration. I think it's 2 weeks. Then you can take your dolutegravir back to its normal level, right? And then Dr. Nchangase, I'm sorry that you are very unhappy. I'm gonna send you my number, Dr. Nchangase. It's 0826576782. I do make time to reply, but it might not be immediate, but I really do try. Okay, Dr. Nchangase, I hope I'm happy that my team was not very helpful. And then our IT officer is here, Dr. Nchangase. You can also share your contact so that we can reach out to you and be able to help you, right? Okay, Asanda, thank you for joining. I hope you've managed to get something from this. Estambuto, I am happy. Lindiwe, I have nursed a failed patient on Tribus, 2 million viral load. And also, this patient, don't switch one drug, Lindiwe. That patient needs a new regimen. So we need proper drug history to know exactly when did they start, what drugs did they take, and then any switchings that happens and the reasons. Then we formulate a new drug for your patient. So you may write me a WhatsApp with proper history. Then we can discuss that patient. All right. Rabelani, you are back. Rabelani doesn't want to let me go. So Rabelani says people who are taking metformin 850 milligrams, 8 hourly. DTG is a no-no. To be honest, the answer is yes, Ravelan, because it will be unfair to change the diabetes treatment. Now they're going to struggle with that. If they are controlled on 858 hourly, please, you know, just leave it at that. Just leave it at that. Letta, is it you? How's Letta? Let me unmute. I need to hear your voice if it's you. Says Letta, a few seconds before you disappear. Says Letta, is it you? You may unmute.
Hi, it's me. Hi, colleagues.
Oh, yes, yes. Ausleta, thank you for joining. Colleagues, Ausleta says Leta is the manager of this program. So I'm sure she's happy that I'm sharing the weight. Says Leta, is there something you want to say to encourage the colleagues?
Yeah, hey, thanks, Dr. Mawela, for operationalizing the circulars just came out yesterday and today, which
Yeah.
you did well. And hopefully they got the first and message.
Yes.
And we'll still look at you to assist with reaching the bigger group in facilities in terms of operationalizing the circular. Thank you very much. Over.
Thank you. Over. That's good. Okay, guys, unfortunately, I can't answer all the questions. What will happen is that I will share, you can continue to share your emails on the chat group. Most of you, I have your emails, but I will then attach everything, the circulars, the slides and stuff. Please don't just take them and save them in your laptop. Do your in-service trainings, empower everyone. And if you have questions, ask me via email and I'll be able to help you. Thank you, says Fumi. Okay, guys, says Mamsi. Bye. God bless you guys.
Bye. Thank you.
Bye, Doc. Thanks for the information.
Bye.
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 Bye, Doc.
Bye.
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 Bye, Doc. Can you please send
Bye,
us your
Doc.
slide?